A very good afternoon and a warm welcome to all our viewers. Welcome to this special session on World COPD Day to talk about COPD and related complications. Now, chronic obstructive pulmonary disease is an umbrella term for respiratory diseases like chronic bronchitis or emphysema that are progressive in nature. Now, it is a long term entity associated with varied complications, the most common being exacerbation or a flare up, in which respiratory system suddenly worsen. So, to commemorate the World COPD Day of the 16th of November 2022, which was yesterday, please join us today for an exclusive session with Dr. Abhinav Guliani. Welcome, sir.
Thank you.
A little bit about the speaker. Dr. Abhinav Guliani is a consultant chest physician and interventional pulmonologist at Sir Ganga Ram Hospital. He has received training for advanced interventions from UCSF, UC Davis, Texas Medical Center, Houston, USA, including cryo-TBB, cryo-tumor debulking, bronchital thermoplasty. He is proficient in bronchoscopy, linear EBUS, radial EBUS, and has an experience of nearly 12 years in the field. Dr. Gulani has been a part of the team, including EBUS cryo, bronchital thermoplasty, and vapor ablation for endoscopic LVRS to North India. It is a pleasure to have you with us here, sir. Over to you.
Thank you. Thank you for the wonderful introduction, Darshika. So today I'll be talking about COPD and some of the nitty-gritties involved with COPD. So first, let me introduce what is COPD. So COPD is a, a common preventable and treatable disease that is chronic, persistent, and the respiratory systems do not go away. They are persistent, unlike asthma, wherein the symptoms would go away for a period and then come back. And it is the hallmark is airflow limitation that is due to airway or alveolar abnormalities caused by significant exposure to noxious particles or gases. Earlier, it was only uh, termed to be a disease which was caused by smoking, but now we know that there are many more things which can lead to COPD, which is basically, in layman's terms, aging of the lung more than the actual age of the person. It is now known to be a heterogeneous lung condition and not just a simple emphysema and bronchitis, which we used to be taught since the beginning. So it is the third leading cause of death worldwide, and it is a major cause for chronic morbidity. Uh, it, at the extreme, there is classical emphysema or chronic bronchitis, but many patients they have a mixture of both, and it can involve either primarily the airways or it can involve primarily the parenchyma, which is the alveoli. So if it is involving purely the parenchyma, it is termed as emphysema. If it is involving the airways, it is termed as chronic bronchitis. So a mix and match of these things happens, and emphysema can lead to hyperinflation, and it compromises the respiratory mechanics, which leads to persistent dyspnea and respiratory failure. So COPD is not curable, but it is both preventable and treatable, as the definition is mentioned. COPD can be prevented by preventing the exposure to noxious particles, or if you are exposed, then you should limit your exposure, and therein you should receive treatment if you are already affected. That has mortality benefit and a whole lot of things. So what the gold what the gold guidelines proposes is that COPD can be differentiated into many ETO types. Depending on the cause, you can differentiate COPD. So this is just a proposition in the current GINA 2023 guidelines, which were released day before yesterday. And this is something which is of a hallmark change, if we can say, because as we knew COPD to be one disease, now it is a part of all these diseases which is proposed. So a genetically determined COPD can be there in young people where there is alpha 1 antitrypsin deficiency and causes changes of COPD. It can be due to abnormal lung development because in early years of life, if there is a premature birth or if there is a low birth weight baby, they can have an abnormally developed lung. Or it can be environmental, where comes the role of cigarette smoking or biomass fuel exposure, and even exposure to smoke in the other forms like vaping or e-cigarettes or cannabis. Exposure to household pollution, air pollution, indoor and outdoor both, can also lead to development of COPD. Now, COPD can also develop as a result of infections. Tuberculosis is one of the most common causes of COPD or obstructive airway disease, as we see in our part of the world. Childhood infections can also lead to COPD in the latter half. Now, there is a variant wherein COPD and asthma can coexist. The gold guidelines now incorporate this as a part of COPD as well, which is also known as an asthma COPD overlap or an ACO. This is particularly when there is a history of childhood asthma and the person has been a smoker as well. That is the most common setting. But there is a only minor difference in the treatment. So that is what I'm going to be talking about in the later slides. So that is how the role of etiology is to differentiate the various types. Now, smoking of all sorts is harmful, as I had mentioned in the previous slide. Even e-cigarettes. Second-hand smoke is also of grave significance because there are many women who develop COPD when the husband or somebody else in the family is a smoker. Sometimes the leftover soot can even affect the baby, which is known as third-hand smoking. Now, smokers can be either heavy smokers or light smokers. Heavy smoking would be more than 20 cigarettes per day. A current smoker is the one who has smoked about more than 100 cigarettes in their lifetime and is still currently smoking. A former smoker would be someone who's quit smoking but has still smoked more than 100 cigarettes a day. A non smoker would count as someone who has smoked less than 100 cigarettes in their whole life. Chula smoking, uh, I'm sorry, chulas or biomass fuel exposure, which is quite prevalent in the rural part of our country, and also crop burning can lead to COPD. Indoor air pollution because of mosquito coils, paints, varnishes, some equipment like air conditioning with their vent placed inside can also lead to chronic changes which are akin to COPD. Now, air pollution, I'm highlighting this because this is the topic in vogue, wherein there is increased incidence and higher mortality of patients of COPD in industrialized urban areas. The exacerbations of COPD are also much more in this subset of patients. The WHO expert committee concluded that a high concentration of sulfur dioxide or black smoke is associated with increased morbidity. So coming to the etiopathogenesis, what does this noxious or a chronic inflammatory stimuli do? It can either narrow the airways or it can destroy the lung parenchyma, leading to loss of alveolar attachments and destruction of the alveoli, and thus leading to a decrease in the elastic recoil of the lung. This decreases the ability of the airways to remain open during expiration, and thus a lot of air gets trapped inside the lungs and causes hyperinflation. This can also lead to loss of small airways and mucociliary dysfunction, causing increased production of mucus, and that mucus can inherently block the airways as well. So, there are a lot of mediators involved: alveolar macrophages and neutrophils, which release proteases and metalloproteinases, which can lead to all of this, as I had described above. This is a slide which I've, or a photograph which I've copied from the from the World Guidelines. Now, this tells us that COPD is a systemic illness. It is not just related to the lung. So, as this slide highlighted, there are so many mediators, the inflammatory mediators, which are released because of the noxious stimuli. Now, they go into different parts of the body and affect the rest of the body as well. Apart from emphysema, airway damage, mucus hypersecretion, it can also lead to cardiovascular diseases. It can also lead to hypertension. It can lead to heart failure. Sometimes extrapulmonary comorbidities can be coexistent with skeletal muscle wasting, low bone density, sleep apnea, depression, and metabolic abnormalities like obesity and insulin resistance can also be induced because of this chronic low oxygen and inflammation, which becomes sort of a vicious circle. How do we diagnose COPD? So first off is the clinical indicator for COPD. So you have to see a patient who has a progressive dyspnea, a persistent dyspnea, especially worse with exercise, a recurrent wheeze or a chronic cough, recurrent chest infections, and with that there is history of noxious stimulus exposure. So this is the setting wherein you have to look for. Tobacco smoke being the commonest noxious stimulus. Others are smoke from home cooking, heating fuels, occupational dust, vapors, fumes, gases, and chemical burning as well. Next comes the role of spirometry. This is a hallmark for the diagnosis of COPD, where you have to demonstrate that there is obstruction in the airways and that obstruction persists despite giving a bronchodilator. So, a post bronchodilator, that means the spirometry done after the inhaler has been given, confirming FEV1 by FVC of less than zero point 0.7 tells us about airflow limitation. So, this is a normal graph wherein most or the 80% of the expiratory volume gets released within 1 second and the rest goes out subsequently. But here you can see this curve where 80% of the volume does not get released in the first second. It takes a whole lot of longer time, and this suggests obstruction of the airways. The other markers are raised total lung capacity because of hyperinflation, raised forced residual capacity because of hyperinflation, raised residual volume because of hyperinflation, and reduced vital capacity because of hyperinflation. The dynamics are such that the person cannot breathe in and out as efficiently as they were. So, how do we classify this airflow obstruction? It can be mild if it is more than 80%. It is graded by FEV1 and not the ratio. Moderate if it is between 50 to 80%. Severe if it is between 30 to 50%, and very severe if it is less than 30%. So this is how we used to divide them first, gold 1, 2, 3, 4. But now things have changed. I'm going to be talking about that. And this is the classic radiology in this setting where you can see hyperinflation, a tubular heart, a flattened diaphragm, a hyperinflation of the chest, increased retrosternal space, which is documented over here. And this is how a CT of a COPD patient would classically look like. So this is emphysema, where the parenchyma or the lung tissue is destroyed. So you can see this is the lung. These are the microstructure of the lung, which is called the lobule. So if it is, these are the septae. If the emphysema is mostly around the septate, it is called paraseptal. If it is mostly, if it is involved in the whole thing, it is called panlobule. If it is upper lobe predominant, it is called upper lobe predominant. If it is lower lobe predominant, it is a heterogeneous emphysema. So how do you assess a COPD patient? These are the things which are involved. First off, symptoms. You have to document how are the symptoms, how is the severity of the symptoms, what is the change in symptoms, what is the degree of airflow limitation, wherein comes the role of spirometry, and what is the risk of exacerbation. So one exacerbation of COPD can lead to further exacerbations. So the risk of exacerbations is determined by previous exacerbation. So if you've had maybe more than two exacerbations in the whole year, that would put you to a very high risk of having another exacerbation subsequently. If you've had one exacerbation in the whole year, that would put you to a risk of an elevated risk of almost 50% to have another exacerbation. So this is the modified MMRC or modified MRC scale to document how severe your dyspnea is. This helps you grade these patients of COPD later. So this is grade 1, 2, 3, 4. We are all very well versed with it. Grade 4 being when you are breathless at even rest, and grade 1 when you are breathless on strenuous exercise. Grade 0 being you're breathless on strenuous exercise. This is also a scoring called the CAT score, which is a COPD assessment test, wherein these are 8 parameters where you have to score them and add up the score in total. So this is helpful in classifying how symptomatic the patient is. If the score is more than 10, it is found to be significant. So these are all available on the GINA website. So, sorry, on the GOLD website. So you can easily go on that. And I'm quoting the latest GOLD 2023 guidelines. So this is the assessment tool where you have to consolidate all these three things which you've talked about and formulate how severe the patient is so that the treatment can be decided. So this is a square diagram wherein on the bottom you can see the symptoms, the MMRC score and the CAT score. If they are less than 0 to 1 or less than 10, it falls into category A. If it is more than that, it falls into category B. If the patient has had exacerbations, more than two moderate exacerbations in a year, or one leading to hospitalization, the patient is known as an exacerbator. Earlier, there were two categories, C and D, divided upon how many exacerbations you were having, but that did not lead into any mortality benefit. So we've classified them now as E. So you also have to assess for comorbidities at all visits: cardiovascular diseases, osteoporosis, respiratory infections, depression, diabetes, cancer, bronchiectasis, sleep apnea, and asthma overlap. Mind you, lung cancer is very common in smokers, so that is something which we have to certainly look for. And these patients should also undergo a screening CT if that is feasible once a year beyond the age of 65. So you would diagnose COPD, your initial assessment would be there, and you would put in the patient on treatment, and then you would review after maybe a few months and reassess or adjust, and this cycle would go on. Now, the treatment part can be either pharmacotherapy or non-pharmacological therapy, which I will be talking about. So the management options involve the drugs which are bronchodilators. Apart from that, these patients should always and always be counseled about smoking cessation, because that has a very direct role in sort of halting the progress of the disease. If you don't quit smoking, the thing can keep going on. Vaccinations are of paramount importance now. I will be talking about that in a subsequent slide. Anti-inflammatory therapies are dedicated for few select patients, which I will be talking about. There is a small subset of young COPD patients where there can be alpha-1 antitrypsin deficiency. So those patients can receive augmentation of alpha-1 antitrypsin, which is a known treatment now. Rehabilitation, physiotherapy, and self-education and management are the cornerstone of a good management, which we should always and always stress upon. These patients who are moribund can be put on oxygen or ventilators, maybe home ventilation by a BiPAP or invasive ventilation, maybe a tracheostomy and a ventilation through that, and palliative care. Advanced patients can also be offered volume reduction and lung transplant. Now, coming on to the drugs. So, beta agonists are one of the cornerstones of respiratory medicine because they help in bronchodilation. They act at the peripheral receptors, beta 2 receptors, and they increase adenyl cyclase and cause a dilation of the muscle. There can be a short acting beta agonist, salbutamol, terbutaline, or a long acting one, salmeterol and formoterol. The newer ones, which are ultra long acting, indacaterol, olodaterol, and vilanterol. Anticholinergics, they act on the proximal or the larger airways M3 receptors, and they cause a bronchodilatory effect because of that. Their effect can also be short acting or long acting. Oxytropium and ipratropium are the shorter acting ones. Tiotropium, glycopyrronium, aclidinium, and umeclidinium are the longer acting ones. So you have to select and channelize what sort of a device, what sort of a bronchodilator are you going to prescribe your patient, depending on the patient parameters, patient's preference, and your need for bronchodilation. So if a patient has come in an exacerbation, you can probably go in for a nebulization because that would be easier for the patient to coordinate. Also, what we certainly recommend is a pressurized MDI with a spacer or a dry powder inhaler, which are equally good in deposition and drug deposition and safety. The pressurized MDI with the spacer has a little bit of an advantage where the molecule size of the aerosol becomes smaller and the deposition in the throat causing local side effects becomes lesser. So this is something which you have to keep counseling your patient about, because 80% of the patients are not taking their inhalers properly. So you have to counsel them, reassess them on each visit. So make sure that is one of the parts of your management, because that is something which goes wrong in most occasions. So inhaled bronchodilations are the cornerstone of symptomatic COPD management. A regular or as needed short acting beta agonist or muscarinic agent improves the FEV1 symptoms. But now what we say is a combination of the two is always superior. In fact, a combination of a longer acting beta agonist and longer acting muscarinic agents is what is preferred now, because that significantly improves the lung function apart from reducing the exacerbation rates. The LAMAs are known to reduce the exacerbation rates in long-term studies. So a combination inhaler of both bronchodilators, longer acting preferably, is what is required and what is recommended. Theophylline or oral molecules like darifyline, doxophylline have been given for ages, but they have a small bronchodilator effect with a modest symptomatic benefit. So alone, they should not be prescribed. And always try to give a single inhaler so that the compliance is the best. Now, what is the role of inhaled corticosteroids in COPD? It is strongly recommended where there is a history of hospitalization or the patient is an exacerbator, because that reduces the risk of exacerbations. Also, if the blood eosinophil levels are more than 300 or there is sputum eosinophilia, that would mean that this patient may be an asthma overlap. So these patients also, we should certainly give an inhaled corticosteroid. But in patients in whom there are recurrent pneumonias or the blood eosinophil levels are less, they should not be given inhaled corticosteroids. So this is how the treatment is recommended depending on these groups. So in group A, you give a bronchodilator of your choice. In group B, you should give a combination of a LABA/LAMA. Similarly, in group E, you should give a combination of a LABA/LAMA. Inhaled corticosteroid should be added if the blood eosinophil levels are more than 300 for sure. And especially we know that these people are exacerbators. So for a short period, if you're adding inhaled corticosteroids in this group, you're not wrong. But I will be coming on to what else can be offered to these patients. Other pharmacological therapies are alpha antitrypsin augmentation therapy or antitussives or vasodilators. But vasodilators which have been used for a long period, which is sildenafil, are no longer recommended because they may even worsen oxygenation and do not have any mortality benefit. So how do you follow up these patients with who are on pharmacological treatment? So the ones with dyspnea, you can start off with a LABA or a LAMA, add on the other one which was not being given, and switch techniques, switch inhalers, and see how this helps. If the dyspnea is still there, then you investigate for other causes and comorbidities. In exacerbators, what you have to do is uh, check for the blood eosinophil levels. If the blood eosinophil levels are more than 300, add an inhaled corticosteroid and see how it goes. If not, then see if the blood eosinophils are at least more than 100. Even then, you can give a trial of inhaled corticosteroids and see how things are. If it is less than 100, you can either give them PDE4 inhibitors, which is roflumilast, or azithromycin, which is 250 milligrams thrice a week dosage, to decrease the risk of exacerbations. This has been shown in studies to benefit. However, uh, azithromycin is preferred in former smokers, and roflumilast is preferred in patients who have features more of chronic bronchitis with a FEV1 of less than 50% as per the recommendations. Coming on to exacerbation of COPD, we are all very scared of exacerbations, so are the patients. And in fact, winters, changing seasons, they are the worst months for them. So, what do you call an exacerbation? So, dyspnea or a cough and sputum worsening over 14 days, less than 14 days, with or without tachypnea and tachycardia. It is associated with increased local and systemic inflammation, and it can be triggered by infection, pollution, and other insults to the airways. The differential diagnosis can be a florid pneumonia, cardiac failure, or pulmonary embolism. So that should be ruled out when you are assessing these patients by relevant tests, as I have mentioned. It can be categorized as mild, moderate, or severe, depending on how and where you are managing the patient. So mild would be wherein you just increase the bronchodilation and manage at home. Moderate would mean that this patient may require admission. And how do you assess this? By symptomatic scoring, signs of tachypnea, tachycardia, sputum volume and color, fever, respiratory distress, and arterial blood gases. So how do you manage it? First and foremost, bronchodilator. So a bronchodilator has to be increased. Maybe the frequency, maybe the drug delivery, something has to be enhanced for the treatment. Corticosteroids form a cornerstone of COPD management because there is local inflammation which has to be settled. So oral corticosteroids or inhaled corticosteroids both can be beneficial in this instance. Antibiotics can be given where relevant, where you feel that there is sputum purulence or there is a patch on the lung. And adjuvant therapy of fluids can be incorporated, or sometimes methylxanthines or oral uh, bronchodilators can be given. Respiratory support in the form of oxygen or non-invasive ventilation like BiPAP or invasive ventilation can be contemplated. So initially you give an acute treatment with a shorter acting agent. Nebulization is easier for sicker patients. You should not give continuous nebulization, rather use them at a gap of maybe 1 to 3 hours. IV methylxanthines are not recommended due to safety, but it is not that they can't be used. In cases where you are pushed to the wall, you can try IV methylxanthines for maybe a day or two to gain that advantage over the severe or tight bronchospasm. Steroids can be given as systemic corticosteroids. Prednisolone to the tune of 0.75 milligrams per kg can be given for 5 days without a taper. So, what are the indications of a patient to be admitted to the respiratory care unit? Either there is severe dyspnea and that responds inadequately to the emergency treatment. There is change in the mental status. The patient is confused, which may indicate that he may be retaining CO2. A respiratory acidosis of less than 7.25 and a PO2 of less than 40 millimeters of mercury on the arterial blood pressure. If you feel that the patient may need invasive ventilation or there is hemodynamic instability, this patient should certainly be in the ICU. If the pH is less than 7.35 but above 7.25, you can try non-invasive ventilation or BiPAP. If the patient has a severely altered sensorium or a massive aspiration, there is severe hemodynamic instability, or maybe a ventricular or supraventricular arrhythmia, this is when you have to think of invasive mechanical ventilation, irrespective of what the other parameters are. So this was how you manage COPD and exacerbations in the routine. But what are the non-pharmacological options? These are the drugs which we've been using in different proportions for a long time. Now, non-pharmacological therapy starts foremost with smoking cessation. You can even give drugs for smoking cessation. You can have special clinics. You have people who are looking after this as a full-time thing, and you should not hesitate in involving them in these patients. Pulmonary rehab is coming up in a big way where you need respiratory muscle strengthening, especially the shoulders where they need to be strengthened, and this will help the patients a lot. Oxygen therapy is beneficial if the resting oxygen saturation is or the resting PaO2 is between 55 to 60. So a moderate hypoxia is where this is required for about 19 hours a day. Earlier recommendation was 16 hours. Now they've notched it up to 19 hours a day of continuous oxygen. BiPAP can also be very helpful in patients who are more symptomatic or who are CO2 retainers, and this has a significant mortality benefit and symptomatic control in these patients. Last but not the least, lung volume reduction. This helps a certain subset of patients, which I will be talking in the next few slides. So WHO and GOLD, they both recommend vaccination for these patients. Yearly influenza vaccine should be given. COVID vaccine should be given, and a pneumococcal vaccine also has known to prevent exacerbations because it helps at least streptococcal pneumonia from to worsen the current condition of COPD in these patients. So pneumococcal vaccine should be initially started off as a 13 valent or a 20 valent one, and then followed by a 23 valent one after 1 year, and this should be repeated after every 5 years. The pneumococcal vaccine has shown to reduce the incidence of community-acquired pneumonia and exacerbations. The American CDC also recommends Tdap vaccination to protect against pertussis in patients who were not vaccinated in adolescence, and also herpes zoster vaccination to protect against shingles in people with COPD above 50 years of age. So, what is the differential diagnosis in a patient I'm so sorry. So, what is the use of CT scan in a stable COPD? So, we've diagnosed, we've been treating, but why do you want a CT? First and foremost, I would highlight lung cancer screening. So, many of these patients are smokers. So, these patients should undergo annual low-dose CT scan to look for or rule out lung cancer. Second comes if you feel that there are frequent exacerbations or the symptomatic control is not good, you can use this to look for other diagnoses which may be coexisting or maybe complicating the issue like a mycobacterial infection, an atypical mycobacterial infection, bronchiectasis. Thirdly, to evaluate these patients for lung volume reduction, which can be done either bronchoscopically or through a surgical method. So first and foremost is bullectomy. If you see a large bulla which can be resected, that would give the lung a lot of normal lung, a lot of space to expand and participate in breathing. This is very, very rewarding, although there is a certain risk involved, but yes, this is something which can be done in patients who have a big bulla. Lung volume reduction surgery can be offered in patients of homogeneous or bilateral emphysema, and a bronchoscopic lung volume reduction can be offered in these patients as well. Lung transplant can be offered to a certain subset of advanced patients in whom the board index is about 5 to 6 and they have problems. So this is the overview of proposed surgical and bronchoscopic interventions in people with COPD. In patients with chronic mucus production, they are trying nitrogen cryosprays and rheoplasty. This is in the phase 3 of trials. In exacerbators, they are trying targeted lung denervation. Just like bronchial thermoplasty, they are using this. Bronchial thermoplasty for asthma, they are using this for COPD. But mind you, this is also still in the phase 3 trial phase. If the patient is dyspneic, we can offer bullectomy, as I was mentioning, large airway stenting, endobronchial valves, endobronchial coils, thermal vapor ablation, lung sealants, lung volume reduction surgery, and lung transplantation. So amongst these, thermal vapor ablation in the endoscopic methods is the only one which is approved and available in India. So if the patient has emphysema, which is of a predominant phenotype with a large bulla, you go in for bullectomy, no questions asked. If there is no large bulla and there is heterogeneous emphysema, which means that the disease in upper lobes is different than the disease in the lower lobes, and this patients, you have to look for the fissures. If the fissures are quite integral and they are present, you can offer these patients endobronchial valves or endobronchial coils, apart from lung volume reduction surgery. Also, you have to look for collateral ventilation, which can probably lead to a failure if you're putting a valve. So if the collateral ventilation is present, then you have to limit yourself to either a coil or a vapor ablation. If there is homogeneous emphysema, the same rule applies and these two things can be tried. But right now, vapor ablation is mainly being used for heterogeneous emphysema. So are the coils and the valves. The lung transplant is one of the options in advanced COPD. The mortality benefit, the age prolongation is coming up to almost 3 to 5 years of age in the centers where they're doing it with finesse. And a PCO2 of more than 50 persistently or a PO2 of less than 60 persistently with a FEV1 or less than 25% predicted is the criteria where they enroll you. The availability of lungs is a major issue. Post-operative infections is a possible issue. So this is something which uh, is an option to explore, especially in younger patients, because you cannot refer a patient more than 65 years of age for a lung transplant yet. Coming on to lung volume reduction, what does lung volume reduction actually mean? So if the lung has a bad area and a good area, you cut the bad area out somehow, and so that the normal area increases in size and participates in ventilation and helps the patient in improving the lung mechanics. Bronchoscopic methods are either by valves, airway bypass procedures, which is stenting, or endobronchial coils, thermal vapor ablation, or chemical sclerosis by means of sealants or plugs. So sealants and plugs was tried in the beginning, which led to a lot of infections and collapse. So this is not very usually used. Endobronchial valves then came into place, which also may lead to some infections. And then came in coils, where because you're putting in something which is staying inside, can get infected. The latest one is the thermal vapor ablation, wherein you put pressurized steam inside, and this causes an auto pneumonectomy by a method of apoptosis, and which is more of a natural method of segmentectomy. So this is the Zephyr valve, this is the spiration valve in place, wherein you see this aperture, which would let the air out, but it will not let the air in when the person is breathing. So that leads to collapse of that segment of the lung and leads to lesser hyperinflation. These are endobronchial coils, which are made of nitinol, and they retain their shape once they are put in. A lot of coils need to be placed, as is demonstrated by this X-ray, wherein you try to pull the lung towards the normal area and lead to a physical collapse of that area of the lung. Thermal vapor ablation aims at instilling heated vapor into the affected segment or the most affected disease segment, wherein it could lead to an inflammatory response and collapse of that segment of the airway. This is a true segmentectomy. So this is what the machine looks like. This is the intervapor uptake medical system. This is the gun with which the steam comes out. This is the catheter, which has a balloon at the tip of it, which can be used to block one segment and instill high pressurized steam. This is a video showing how and with what pressure the steam comes out. The catheter is attached over here, which goes inside through the normal bronchoscope. This is a video which of a procedure which we have recently performed. So vapor ablation would mean that you take the catheter, block the segment, and instill steam so that later on in a few months, this area would get apoptosis. So this is a patient in whom we've offered this and done this procedure recently. You can see that this is a severe COPD, and this was what the CT scan would look like. Upper lobe predominant emphysema with some cicatrical changes in the right upper lobe. They have a fixed software in which they feed the CT scan and calculate which area would benefit the most. And as you see, the lower lobes are less affected, which is very evident. This is how they calculate and tell you that which area has what percentage of the disease, and by destroying or blocking what area, how much of benefit would you sort of achieve. So what they calculated and told us that if we uh, sort of apoptose both the upper lobes, this would help this patient. So this is a video of the procedure being done. This is the right upper lobe, and this is the affected segment which we intend to block. This is the catheter which is being inserted into the subsegment of the right upper lobe anterior segment, and we would use the tamponade balloon which is placed in the catheter itself, and we would seal this segment. After sealing the segment, we would check whether this is absolutely well sealed by moving the catheter back and forth, and then instill steam for the given period of time, which is up to almost 10 seconds, which would deliver the appropriate energy, causing inflammation and subsequent apoptosis. If you can see in the inset over here, you can see the steam going through into the affected segment. This is very safe, very easy, and hardly takes about 10 minutes. And you can see that the mucosa has sort of blanched after we have put the pressurized steam inside this lobe without causing any damage to any of the adjoining structures. This is just a mucosal hypervascularity, which you can see there is no bleed, and this is a relatively safe procedure. So this has been backed up by various RCTs. This is the step-up RCT, which was done recently, and it demonstrated that the FEV1 improvement was tremendous, up to almost 15% in these patients. The improvement starts at 3 months and carries forward further to 6 to 12 months, and it is a sort of persistent improvement. It is clinically and statistically meaningful. And this is the symptom assessment wherein the SGRQ score showed a significant improvement, and the improvement was sustained. So this is a one-time thing, and which has a really good response. So if you compare the bronchoscopic lung volume reduction procedures, valves, coils, and intervapor, as I had pointed out, for valves, you need to have fissural integrity, and no collateral ventilation. That would mean that that lobe of the lung is not being fed through air by any other means. So that is something which is very difficult. There is a high pneumothorax rate, and there are long-term implant complications associated. Such is the case with the coils as well. Although the fissural integrity is still required, but collateral ventilation should not hamper because you are physically reducing the size of the lung. But yes, there can be pneumothorax, there can be hemoptysis, and there are long-term implant complications as well. Whereas vapor has not been reported to cause either of these. There is sustained FEV1 improvement and SGRQ improvement in vapor, whereas it is still doubtful with valves and coils whether both these things are there or not. So, in conclusion, lung volume reduction is a viable option after medical therapy has exhausted. At present, many bronchoscopic options are available, but at present in our country, only vapor ablation is there. And I'm proud to be a part of the team where we have introduced this in north of India. and we are the only center doing it. Availability, patient preference, cost, and complications are something which you need to consider before offering this to your patient and evaluating your patient for this. Nothing happens without a team. This is my team from Gangaram Hospital, and I thank you very much for a patient list. Over to you, Darshita.
Thank you so much, Dr. Kuleni. Wonderful presentation, very well explained. A couple of questions we have for you.
Sure.
We'll take this. So my first question for you is from Dr. Deepak Rastogi, who wants to know the role of statins in COPD.
All right. So statins, like in many diseases, have been shown to reduce inflammation and cause mortality benefit. But for COPD per se, they have not demonstrated any change in the symptom or the exacerbation profile. However, in patients who have comorbidities, especially cardiac comorbidities, that is the patients in whom we would recommend statins.
Okay, sure. Thank you so much. Okay, moving ahead. Another question for you, since you mentioned that COPD is a slowly progressing disease, which means lung function declines slowly. So, what should
Yes.
physicians do to identify this decline early and help the patient? Now, this question is mostly, applicable for general physicians or family physicians who are the first contact for such patients.
So you have to be very intriguing in asking about breathlessness. So even the slightest change of the symptoms in terms of breathing difficulty on strenuous exercise should point you towards some amount of airway disease, and that is the time when you should order a spirometry. You should not hesitate in getting a spirometry done. Get it done from a good center where the technician is competent enough to achieve all the parameters well, and the PFT becomes reproducible and a good one. So the PFT and a screening PFT can also be incorporated in daily practice, which can help these patients, especially in those who are in the risk group, smokers, passive smokers, or especially elderly above the age of 50, wherein you would suspect that they've been in an urban setup or they have some risk factors pointing towards that.
Rightly said, sir. I think moving ahead, now apart from having statutory warnings on cigarette packets, how
Mhm.
can the government involve physicians also to reduce cigarette smoking, thereby reducing the cost on Indian healthcare? So, something more on the policy lines.
Right. So I feel smoking cessation is something which is of paramount importance, and the we should, as a nation, sort of look into how to go about it. There should be more of public lectures, as the government had also started that before movie screenings, they would play a video of the impact of smoking. More than that, they should also have certain general awareness lectures which can be delivered to the targeted population. So generally, people start off when they are at a younger age, maybe at a college level. So that is where we can probably strike and create a lot of awareness, so as to telling them that this can lead to permanent changes, and that is something which can probably help.
Thank you so much.
Second thing can be there can be monetary rewards for quitting, which can
Okay,
which are known to help in certain other places to help people quit.
thank you so much. Makes a very relevant point, sir. Um, One last question before we close. So,
Uh-huh.
it is found that COPD is associated with osteoporosis. So, could
Mhm.
you enlighten us about that?
Yeah. So many COPD patients are smokers, which also leads to osteoporosis. Second, there is a lot of systemic inflammation which is induced because of less oxygen, and that also leads to osteoporosis. So that is one of the significant comorbidities which we should look at, especially in elderly females. Because of hormonal changes, females are more prone to osteoporosis, and that is something which we should look into and maybe get a DEXA scan and institute a formal therapy if we see that osteoporosis is there as a part of management of comorbidities.
Okay, thank you so much. So, this brings us to the end of our question answer segment. Sir, any closing remarks or any message for our audience who's watching us live here?
So my only message would be quit smoking, identify COPD early, and Make sure that you are seen by a physician. If you are having the slightest of the symptoms, do not ignore your symptoms. That is what we usually do.
Thank you so much. Thank you so much, Dr. Gulani, for being here on the occasion of World COPD Day. Thank you so much for being here with us. Thank you so much.